will be recorded, and it will also be placed on the DCH website. I'd like to welcome you to the Department of Community Health Hospital virtual meeting. Today, the department will present, along with our partners, Myers and Stauffer and 3M, information on the department's transition from Tricare DRG group of version 35 to APR DRG group of version 40, effective January 1, 2024. Joe Gammis with Myers and Stauffer will present information on the APR DRG transition, and Linda Bentley with 3M will provide an overview of the APR DRG grouper. The department asks that providers hold all questions until the end of the presentation. We also encourage providers to submit their questions in writing. At this time, I will start the presentation and turn it over to Joe Gammis. Let me know if you all are able to see the presentation.
I can see it, Kim.
Okay, all right. Thank you very much. Please keep your mics on mute, please.
All right. Thank you all. As Kim said, my name is Joe Gammis, and I'm a senior manager with Myers and Stauffer, who has been working with the department over the last several months to get this Rebase and APR DRG transition implemented and modeled. So we'll move on to the next slide, please, Kim. All right, just as Kim stated, please enter any questions into the chat box during the presentation. They will be addressed at the end of the presentation. Additionally, if there's any questions that you have that you would like to submit directly to Kim or Shauna, please send directly to their email boxes. Okay. I'm sure most of you are already very familiar with the system as is, but just wanted to give a historical perspective. The last rebase occurred or was effective January 1, 2019. Currently, the direct GME is paid based off the surveyed FTEs at the facility. That is an updated as annual update. The current weights are the Tricare version 35 with state-specific cost-based weights calculated for them. And the cost to charge ratios are updated on an annual basis, which you all receive rate sheets on for the 7/1 effective dates when those go live. Next slide. The current hospital base rates are as such. There is a statewide rate calculated as $5,310.99, and then there are several rate add-ons that are calculated. Now, only one of these is updated on an annual basis. That's flagged below, but I'll walk through each one. The Meyer adjustment, the Medicaid inpatient utilization ratio adjustment, was calculated for the January 1, 2019 basis. It is a tiered schedule of a 2% add-on up to a 10% add-on based on the calculated percent of Medicaid utilization at the hospital at the time of the last rebase. The indirect medical education add-on is reviewed and updated annually based on the submitted FTEs that are utilized within the direct medical education supplemental payment that is calculated. So those FTEs are utilized in both the direct and the indirect, and they're updated annually. There is a pediatric peer group add-on that is for the three pediatric hospitals in standalone hospitals in Georgia. And then the stop-loss stop-gain adjustment was calculated as a one-time stop-loss stop-gain as of the January 1, 2019. That is a adjustment that is frozen and is not updated annually. Next slide. Thank you. Okay. So walking into the new rebase, the calculated data sets. So we have, the system is calculated using the calendar year 2022 claims, using the 2023 DISH payment surveys, and if no DISH payment surveys were submitted, then the FYE 2021 cost reports were utilized as a fallback for the data that is calculated with the DISH surveys. One thing to note in this is the rebase that is effective as of January 1, 2024 is calculated to be budget neutral per provider to reduce any impact or any estimated impact that may occur for the APR DRG transition. That is calculated through the stop-loss stop-gain mechanism that would be included in the base rate add-ons. Next slide, please. Okay. So it's been mentioned before, but the implementation of the APR DRG is effective January 1, 2024. The system is moving to version 40 of APR DRG, which was released last October. The DRG weights and the outliers thresholds have been recalculated, so part of the rebase. The DRG weights and outlier thresholds are again calculated at a state-specific cost-based weights, and the outlier thresholds have been reset to accommodate the new APR DRG system. The proposed system that will go into effect January 1, 2024 has an updated base rate of $5,985.86. The base rate add-ons are all the same that are there. However, they have been evaluated and updated. So each hospital will receive an updated Meyer adjustment calculation, a IME adjustment that actually would be the same one that was utilized in the July 1 update, since there was no newer data. The pediatric hospital peer group add-on is the same as before. That was reviewed and it was determined to hold steady at that add-on amount. And then the stop loss, stop gain, as I mentioned before. This is now utilized as a budget neutrality mechanism for every single hospital. So the decision was made to ensure that hospitals had minimal financial impact due to the transition to APR DRG. So the stop loss, stop gain is essentially set at 0. It is holding every hospital to a estimated gain and loss to 0. And additionally, the cost to charge ratios, which were already put effective July 1, there is no change to those as they were already put July 1, 2023. Okay, so we are pleased to have Linda Bentley here. Linda is a product owner for the inpatient groupers from 3M Health Information Systems. She's going to kind of give a quick overview over APR DRGs holistically, and then I'll come back right after that. So Linda, I'll pass it off to you.
Okay, is Linda with us?
Linda, you may have to take your phone off mute.
Hello, can you hear me now?
Yes, we can.
Okay, let's see. Okay, thank you so much. I'm very happy to present the APR DRG overview. If we could go to the next slide. Okay, so what is the Outpatient Refined Diagnosis Group? It is a classification system that classifies patients according to their reason of admission, severity of illness, and risk of mortality. To further define severity of illness and risk of mortality, the severity of illness is the extent of physiological decompensation or organ system loss of failure, and risk of mortality is the likelihood of dying. The patient's characteristics that are used to define the DRGs are usually found in the hospital's abstract system. APRs have a manageable number of DRGs, which encompass all patients seen on an inpatient basis, and each DRG contains patients with similar pattern of resource intensity, as well as patients who are similar from a clinical perspective. Okay, if we go to the next slide. This is the structure of the summary of the APR DRGs, very similar to Tricare until we get to the severity and risk of mortality. So we start with our MDCs. There's 25 MDCs and pre-MDC. And then they are divided to base DRGs. So the Outpatient Refined Diagnosis Group base DRGs are then expanded, adding 4 subclasses to each DRG. These 4 subclasses address patients' differences related to severity of illness and risk of mortality. As you can see, the severities are numbered sequentially from 1 to 4, minor, moderate, major, and extreme, although the subclasses are numbered are represented as values, more like categories, not scores. Therefore, it is not meaningful to compute an average severity score. In addition, APR DRGs of SOI and ROM of a patient is specific to the base APR that the patient is assigned to. So if we go to the next slide, I have a sample here, and it's showing a severity of illness and risk of mortality. And you can see they are independent. They are calculated separately. So acute cholecystitis is a good example of this. For instance, if you have acute cholecystitis, you would be a severity of illness of 3, which is a significant organ decompensation. However, the risk of you dying is very low, so your ROM is a 1. So let's go to the next slide and just a few examples of the progressions of a diagnosis for both SOI and ROM. As you can see, I'm going to go through minor, which is a type 2 diabetes mellitus without complication, where a moderate would be a type 2 diabetes mellitus with diabetic chronic kidney disease. Major would be other specified diabetes mellitus with ketoacidosis without coma, whereas a severe would be your type 2 diabetes mellitus with hyperosmolarity with coma. Now, on the other hand, your secondary diagnosis of dysrhythmias, a minor would be a cardiac arrhythmia unspecified, where moderate would be your 6 sinus syndrome, 3, which is major ventricular tachycardia, and severe ventricular fibrillation. So you can kind of get a feel of a minor versus severe. The one thing that is very important as we go through our APR DRG methodology process is it is very important to code all diagnosis and procedures. Whereas in Tricare, once it reaches an MCC or CC, it puts you in the appropriate DRG, where APR it looks at every diagnosis and procedure, and based on the process, it will assign you a final severity of illness and risk of mortality. The process is first assigning the base APR DRG. The next step is phase 1, where we determine the SOI and ROM for secondary diagnosis based on 6 steps. Then we go into phase 2, which determines the base severity of illness and risk of mortality based on 3 steps. And then lastly, phase 3, we determine the final severity of illness and risk of mortality based on 9 steps. So within these steps, we look at every procedure diagnosis, we look at combinations of them, we look at age. So there's a lot of factors that go into this process. Okay, so if we could go to the next slide. So just a few comparisons with Tricare compared to APR. They both have annual releases with the possibility of an April update. The data requirements are similar: diagnosis, procedures, age, sex, discharge status, and birth weight. They both have the same MDCs, a pre-MDC plus 25 MDCs. However, the base DRGs differ. In Tricare, in version 35, there were 819, whereas in APR for version 40, there's going to be 333 base DRGs, but then when you multiply them by the subclass, there is 1,332 plus 2 error DRGs. As far as data for the DRGs, they're both a 3-byte DRG. However, with APR, there's an additional 1-byte field for the SOI and another 1-byte field for ROM. So if we go to the next slide, as you all know, in Tricare, there are age splits at the DRG level. However, for APR, the base DRGs are not differentiated by the age, but the SOI and ROM subclasses are modified by patient age. And the other difference is with the discharge status. So with Tricare, MDC5 uses the discharge status of died. MDC15 uses both the discharge status of transferred and died. And MDC20 uses the discharge status of left against medical advice. Whereas APR, MDC15 is transfer only. And MDC20 also uses left against medical advice. Okay, if we go to the next slide. So how can APR DRG output be used? It can assure all patients are measured by the same standard. It's used to stratify all patients in conjunction with other metrics, such as looking at severity against cost, length of stay, complications, and readmission, measuring severity to ensure patients receive the right type of care based on severity, designing clinical pathways in support of severity. It also assists in profiling physician performance. It can demonstrate the need for appropriate collaborative and comprehensive documentation, assist in quality reviews, prepare for public reporting, and using the case mix index to ensure fairness and reimbursement. And if we go to the next slide. So if you want to dig a little deeper, if you go to www.aprsassign.com, you will see the APR methodology overview as well as the definition manual. In addition, there is a single claim interactive grouper for DRG assignment review. So you can actually go in and enter in your patient information and group using APRs. In order to do that, the users must register the website, and your registration code is GAHOSP as noted on the slide. I appreciate your time and thank you for letting me present.
Thank you, Linda. All right, come back here for a couple slides and then we'll get to the Q&A portion. So the proposed timelines, we have been working with DCH and 3M for the system calculations and modeling most of the summer. We supplied the initial proposed system to Gamewell just for them to start the process of them updating the tables and the all of their back-end software. Today, presenting to the industry group. And then in the coming weeks, the estimated rate sheets and the DRG weights will be released to the industry for the hospital's review. Additionally, coming in the fall, the date is still to be determined. There's going to be an additional far more in-depth training from 3M on APR DRG as a whole. And then currently the effective date for this Rebase and APR DRG implementation is January 1, 2024. All right, and then future updates, just kind of give you a projection of the future. Currently, the annual updates that occur in July 1 will begin occurring again as of next July 1. So the same system parameters that are updated annually currently, the indirect medical education, the graduate medical education, and the cost to charge ratios will all be updated once again in July 1, 2024, utilizing the new APR DRG system. Next slide. And from there, we will open the floor with questions. As Kim kind of pointed out, if you could put your questions into the chat so that there is a record of the questions, just so we can kind of create a FAQ as well. Additionally, if you have questions that you would not like to submit in the chat, you can submit to Shauna and Kim at the email addresses below. With that, I will pass it back to the DCH team.
All right, thank you, everyone. If you have questions, there's a little raise hand feature. Please do that. We'll be checking the listing of the participants to make sure we answer any questions that you have that we can at this time. But again, if you can put your questions in the chat, as well as if not, email them to us so we can have a record.
Thank you, Kim. Thank you, Joe. So this is showing that the questions are coming into the start with the
I see
first
that.
one.
Okay,
You want me to
So
go
we
ahead
have a-
and read them?
you can, Shona, that's fine.
Okay. The first question is, how is the APR the Medicare DRG table? Will the proposed change adversely affect small and rural hospitals?
I can take that one, Kim and Shauna, if you like.
Yes.
So the APR DRG table is different from the Medicare DRG table. However, they are released on they are released at the same cycle as of 10/1. The DRG weights table will be released in the coming weeks. That would be applicable to Georgia hospitals. And will the proposed change adversely impact small and rural hospitals? Currently, as stated in the presentation, the system is calculated to be budget neutral per hospital. So every hospital is receiving a customized base rate with the estimation that that will limit financial impact to each of the individual facilities.
Okay, thank you. The next question, are there any planned changes to the direct GME reimbursement formula?
At this time, this is Kim. At this time, there are no proposed changes to the GME.
Next question, thank you, Kim. How will the outliers be calculated?
The outlier formula is unchanged. The only change is to accommodate the APR DRGs. There was an updated outlier threshold per DRG built into the new system that is exactly the same as how Tricare had a per DRG outlier threshold. Again, that will be released on the DRG weights table that will be submitted to the industry in the coming weeks.
Thanks, Joe. The next question, will you email the handouts to each person on the call? I believe, Kim, we're going to have those posted. Is that correct?
Yes, we're going to post everything to the website so that you all will have access to all the information. We're going to see when we send you the rate sheets to see if we can include the presentation. It just depends on how we set up the mail merge. We will try, but if not, Natalie, it will be on the website.
Thank you. Next question, will the CCR be derived from the filed ICTF? And second part of that question is, will the CCR be derived from the filed ICTF DISH surveys?
There's no change in how the CCR will be derived. It will be derived from the DISH payment surveys that are submitted annually.
Okay, thank you. Kim spoke about the presentation, so I'll go on to the next question. Will the change to APR DRG change the reimbursement? Did I read that question correctly?
So that's the short stays.
I'm sorry, will the change to APR DRG change the reimbursement based on CCR for 1 day stays? Yes.
No, that will not change. The underlying calculations of the DRGs are being maintained. The only change is the moving from the Tricare grouper to the APR DRG grouper. And with that, we had to recalculate the weights and the outlier thresholds at a DRG level. But the system calculation steps are being maintained.
Okay, thank you. And I think you already addressed when the DRG weight tables will become available, Joe. I think you already addressed that. The next question, it's a little long, so The prior DCH presentation on APR DRG Rebase indicated that calendar year 2019 was going to be used as a study period to develop the new APR DRG factors. Similarly, was previously indicated that the data utilized from GAMUS and Encounter that is submitted to software has diagnosis and procedure codes out to 10 for each. Based on the presentation, it looks like 2020 is instead being used as a study period. Did the state also provide all ICD-10 procedure and diagnosis codes to Myers and Stauffer, or was the 2022 ICD-10 diagnosis and procedure data limited to 2022 as previously indicated, only to 10 codes versus all 25?
I'll take the first part of the question. As we've been working with Myers and Stauffer to develop the model, we've looked at utilizing different base periods, and the state decided to use the most current base period, which was 2022. And Joe, I'll let you handle the rest of the question.
Yeah, as the system only captures 10 of each, currently that is what we had to model with, as that was the best available data at the time of modeling.
You. Next question, will the add-on calculation 11.88% remain the same? I believe that's going to remain the same. Kim, would you say?
Yes, we have not made
No
any
change to
changes
that.
in the calculations.
Next question, will we be sharing the impact analysis for each hospital's reimbursement team for review? That would be included in the rate sheets, would you say, Joe?
Correct, that is in the rate sheet package.
Thank you. Next question, will DCH be providing an inpatient calculator? This is provided by some state Medicaids. Inpatient calculator.
Is that this? I'm not sure. Let me check and see if that is the same thing that Linda was referring to as far as for the hospitals. But with that, we will talk about asking some hospitals to volunteer as a part of the claims processing with Gamewell. And so after we did the question and answers, I was going to give a little bit more information on that.
Next question, will the CMOs be expected to move to the APR DRG as when the response to that is yes? And next question, will an outlier payment automatically be included, or will providers have to continue requesting the outlier payment after the initial DRG payment is received?
That process for the outliers, none of that is changing.
Thank you, Kim. Yes, the presentation will be posted on the DCH website. That was the last question so far.
Okay. All right, thank you. And if you have any additional questions, please put those questions in an email to myself and as well as Shauna Johnston. And as Joe has already alluded, we will be doing an FAQ that would also be posted on the website. One of the questions, we are working with our MMIS vendor, Gamewell, and what we want to do is we want to set up some testing of claims. So we're asking any hospital that would like to participate in the testing, if you could please send me an email giving me your hospital name, the contact person that would be willing to work with Gamewell, as well as their email address. And we'll be giving you some dates for the testing. The testing is going to be done in 2 periods. One is probably going to be in October and one shortly after. And so we want to try to get the hospitals involved. The main thing is we want to make sure that everything is in place and that all the claims processing is is accurate before we go live on January 1 of 2024. I think we may have another question that came in.
Yes, you have two more.
Okay.
All right. Will the state provide the APR DRG file for hospitals to be able to upload to be uploaded into their DRG dictionary?
I think, Joe, that's what we've given to Gamewell, and we'll be sharing that with the hospitals.
Correct. That'll be the DRG weights file that includes the weights, the short stay transfer eligible DRGs, and also the outlier threshold per DRG.
Next question from Stephanie. Am I understanding correctly that MCD is moving from Tricare to APR DRG, and it will calculate differently using SOI and ROM, which could result in different DRG than previously, which could result in a difference in payment?
That is correct. I think as Linda stated in her presentation, there'll be we'll go from, I want to say, let me go back to that. I don't want to misspeak. But we'll go from 819 to 1332. So there is that possibility. But there's also the possibility that there could be an increase in payment too. So it's not one-sided.
And Kim, I would like to add to that. So the system will calculate based on the DRG assignment plus the SOI. That is how the DRG weights have been calculated. And when you receive the DRG weights file, you'll be able to recognize, it'll lay out just like the Tricare file where it's a DRG dash SOI, and then there's an associated weight to that assignment.
And may I add to that, there is a difference between the Tricare DRGs and APR, so you will see differences as mentioned.
Thank you.
Okay.
Next question, will DSH update the APR? Sorry, you were saying something?
No, I was letting you read the question.
Okay. Okay.
So
Will
the question, go ahead.
update the APR? Will DSH update the APR DRG weights annually, or will they remain static for a number of years? For example, we're still on Tricare version 35.
Okay, that hasn't been decided, the frequency as of yet. There's a lot of variables that go into us making that decision, but as of right now, I don't have an answer for you as to what's going to happen in the future.
The next question, when will the file be available to providers? I think Joe said that over the next few weeks, we'll be able to get that information out to you. The files that you would need to get these into your system. Next question, is the stop loss, stop gain provision temporary or permanent?
Again, that is something that the department would be evaluating at a later date. As of right now, I don't have an answer for that.
Okay. Next question, the go live is still planned for 1/1/24, no additional delay. I'll take that one. Yes, we still are on track for a 1/1/2024 effective date. Now we're on, that's it for now. Of course, if anything major happens, we would notify the provider community. But as of right now, we are on track for 1/1/2024. All right, that's the last question. Chat, Kim.
Okay. Well, no, again, if you have any questions going forward, please send those questions to myself, Kim Morris, or Shauna Johnston via email. We will be preparing a FAQ based upon the questions that we just went through, as well as any additional questions that came in. At this time, I'd like to thank everyone for their participation. Thank Myers and Stafford, Joe Gammis, and 3M Linda Bentley for their portion of the presentation. With no questions, thank you all and have a good rest of your day.